So, my talk this evening is on microsampling of antibiotics to support PK studies in paediatric patients. And I really enjoyed Stefan Sommer's talk, and I think a lot of what they were saying really leads into some of the perspective that we've encountered from the PK studies, and particularly in the paediatric patients. In my talk this evening, I thought I'd give you a broad overview of the importance of PK studies in paediatrics, that clinical perspective, which I think is so valuable in our understanding of the importance of it, and then also just run through the advantages of microsampling and where we've been sitting with PK studies. It is tempting to stray into other areas of the application of microsampling in clinical studies, but tonight I'm really going to try and stay in my lane and stay in this area. Hopefully I won't stray. But I'd also like to then give you an update of where we're using microsampling in PK studies, the perspective of carers and nurses, and also the industry perspective of that application of microsampling. And then some of the future challenges that I think we're facing. Just broadly, in paediatrics, severe infection is a major cause of mortality in the paediatric intensive care unit. 26% of patients admitted to the PICU in Australia and New Zealand across a 10-year period were found to have severe infection. 5.6% of PICU patients with sepsis will die. 17% with septic shock. And if a paediatric patient requires organ support, so they might have organ failure, so kidney failure or lung, then 50% of those patients will die. So the standard therapy for sepsis or severe infection is IV antibiotics. They may get inotropic or vasoactive agents to impact on their heart rate, volume expansion, surgical interventions for source control. They may also be intubated, have ventilation, extracorporeal life support. So this would be where they'd have and renal replacement therapy. And that's that organ support for organ failure. And as much as I like to see chubby little toes, the reality for an intensive care unit is this is what a paediatric patient can look like. And so faced with this, we were really approached with the question from our clinical collaborators, which is a weight-based dose that's been derived from a study in a healthy adult suitable for this particular paediatric patient? We know that critically ill adult patients have altered pharmacokinetics. We know that the use of ECMO, of renal replacement therapy circuitry, the tubing, the filtration membranes can all sequester the antimicrobial and reduce the concentrations of the available antimicrobial from the patient. And so it's really based on our clinical collaborators approaching us that we moved on to pharmacokinetic studies. And so just a basic overview, a pharmacokinetic study, sorry about that, is where we'll be collecting multiple studies across a dosing interval because we're trying to understand the absorption, distribution, metabolism and elimination of the drug from the body. And from that, we can optimize dosing suitable for a patient. Our area is particularly in post-licensing, so an antimicrobial will be available, but we're looking at its use in special patient populations, and these aren't considered during the licensing process. So we look at critical illness and in pediatrics. And as you can see, when you're looking across a dosing interval and you need to collect multiple samples in that interval to get a really good feel for the way that drug is responding in the body. the distribution, its volume across the body, and the way it's being eliminated. And if you reduce that number of samples, you can impact on the accuracy of the of your understanding of the pharmacokinetics in the patient, and that can then impact on the dosing that you might recommend for that patient. And so the challenges of dosing antibiotics in paediatrics. So in 2016, we looked at all of the studies that had been performed in critically ill paediatric patients. And we found that there were 20 studies in paediatric patients and 13 in neonatal patients. The large purple circles there are the paediatric patients. 40% of the studies that had been performed had a patient cohort of less than 15. And some of the studies collected only 1 or 2 blood samples per patient. These studies would use a population pharmacokinetic approach to try and understand patient variability, interpatient, but it's likely that when you've got that reduced number of samples, it is going to impact. Almost all of the authors identified pharmacokinetic changes in their critically ill patients compared to a healthy patient. And they all recommended either further pharmacokinetic studies in this patient population or therapeutic drug monitoring to support optimal dosing. So then we thought about the use of microsampling for pharmacokinetic studies and what the advantages of microsampling were. And, you know, in the neonatal and pediatric patient, that reduction in blood volumes is significant. But further than that, you can also see a simplification of obtaining the sample. So samples can be taken from a finger or heel prick rather than a cannula or venipuncture. But for us, in the PICU or the NICU, this might be of less value. The patient is going to usually have a line available to collect a blood sample. But still, that blood volume is an impact if you're trying to perform a pharmacokinetic study on top of their clinical care. There can also be simplification in sample processing. So you don't need a centrifuge to fractionate plasma if you're using a different type of microsample or you're using whole blood. And there are devices available that can remove red blood cells prior to creating a plasma sample. There's also a reduced cost of shipping and storage, and this allows you to perform studies that you might not have otherwise been available. But these advantages, as I mentioned, don't always suit your patient group. And that's one of the considerations, and certainly this is what Steph and Soma were speaking to, is that discussion needs to occur at the beginning of, you know, during that study design phase. And we have had a review paper in which we looked at the role of microsampling in antibiotic pharmacokinetic studies. And we devised a contingency approach where we were considering the patient, the antibiotic, and the location of the patient. And the idea about it was that there's no perfect microsample for every patient. And so your decision on what is going to be the best microsample will be dependent on those 3 issues. The other part of that paper was identifying that a lot of the current technology of microsampling was being underused due to a lack of bioanalytical methods and bridging studies. And I also have a paper that was just published recently in 2020, because this is a more recent understanding of microsampling, which is where they're trying to enable broader adoption of microsampling into clinical studies. And I'll talk a little bit more about, you know, where we now see microsampling in these PK studies. So from from the things that were slowing the uptake of microsampling was a lack of bioanalytical methods and then bridging studies or correlative studies to support the use of them. And so when I looked just since 2016 and I tried to pull up some papers on microsampling methods that are being designed for pharmacokinetic studies using microsampling, there were many. And it's really good to see this is really, this enabling of microsampling into the clinical area. And, this is just a small sample and certainly tried to stay in the space of pediatrics, but there was, certainly so many papers available. And I also tried to stay in the space of infectious diseases just to narrow the field. Correlative studies, there's fewer, but there's still certainly many studies that have come forward. Again, just trying to stay in my lane. These were the 5 that I identified. And the purpose of these correlative studies is to establish this matching between the 2 measurements, but it also allows us to understand limitations of assays and ensure that the drug concentrations that we're able to measure are going to support pharmacokinetic interpretation. The paper I mentioned before from the Land O'Lakes workshop on microsampling in 2020 identified that the use of correlative studies is important where you're moving away from a traditional sampling matrix. So you might be moving from a dry blood spot to a plasma spot. They also suggested that we avoid these studies in neonatal patients, but perhaps obtain representative samples from those patients within a larger study of higher age paediatric patients. The 2020 paper also discussed the statistical analysis behind the correlative studies, which I think was really is really valuable because there was some discussion and I guess some confusion within the scientific community of what was needed to understand to accept microsampling. And so it looks that generally we're falling to the use of the incurred sample reanalysis test, which is we can use a bland Altman to display that visually to understand systematic bias. Also, the number of samples, we look to be settling to about 30 to 40 data points from a larger number of individuals. So 2 paired samples from 20 individuals rather than 5 paired samples from 8 individuals. So I thought I'd take a look through the analysis of some of these studies, just to give you a bit of a feel for I guess, how people are looking at the suitability of microsampling. This is a study where they were looking at vancomycin and creatinine in plasma using VAMS devices. And I've only just got the vancomycin data here, but here they presented a passing block with a bland Altman. And so what they did here with the analysis was they compared plasma to VAMS, and they found there was a mean bias of around 9.5%. But when they used the passing Bablock correlation in the bland Altman to correct for the vancomycin, the bias that they saw, they were able to, they actually found a correlation of 0.4%. And then they also just tried using a correction factor, and they found that they had a mean of 2.3%. So both of which were really good ways of correcting for the difference between plasma and VAMS. The next study is one from one of our previous speakers, Lawrence Manning's group in WA, and this is where they looked at use of dry blood spots, ceftriaxone, for measuring ceftriaxone in Papua New Guinea. And rather than using an approach of the correlation using a passing bad block or a bland Altman. What they actually did was used a pharmacokinetic model. So they designed the model using plasma concentrations and then looked at the relative difference in the PK parameters for the DBS. And I think what's of value here is the FDA requirement is always that the methods that we use are suitable for their intended purpose. And if the purpose is a pharmacokinetic study, you would want to see correlation with the pharmacokinetic parameters. And here you can see really nice correlation of clearance and the central and peripheral volumes. And the intercompartmental rate was just narrower within the with the dry blood spots. So in a similar manner, the other thing I did mean to mention, in this study, they also performed an adjustment for red cell partitioning and a hematocrit bias. So it was once they incorporated that, they were able to achieve these results. They also noted in the paper that when they were collecting the samples using conventional sampling, it required the removal of 3 mL of blood and flushing with normal saline on each occasion. And that's the normal process in an IV where you're trying to clear the line. So there is a discard. So when we say we're collecting 3 mL of blood or 1.5 mL of blood, there is still this discard volume. And I think that's an important feature because it is a larger volume. Despite that large discard and the flush with saline, they did find that there were 2 samples that had physiologically implausible ceftriaxone concentrations, which suggested that care needs to be taken when using this approach for plasma sample. And that is really our conventional technique for collecting samples. And this is a study that we've just recently published on ceftaxime in critically ill paediatric patients. And like the last study, we moved our analysis into a pharmacokinetic model. And so what we did was we used our conventional plasma samples to derive the model, and then we performed an external validation using capillary microsampling data. And what you can see on the bottom left-hand side of the screen, the top is the ceftaxime, the bottom is the desacetyl ceftaxime, and with the observed being the capillary microsampling data, and the predicted is the model predicted concentrations from the conventional sampling. And you can see there we've got really nice bias between the 2 results. But when we also included in that our bland Altman and scatter plots of the raw data rather than the model predicted concentrations. And you can see there we have a bias for ceftaxime of 8.8% and desacetyl ceftaxime was -9.2%. And just further to the exclusion of the samples from the previous study, we also excluded 5 samples from our analysis, and all of those samples were peak concentrations from our conventional plasma sample. And again, this to me highlights one of the potential benefits of performing pharmacokinetic studies with microsampling is that elimination of a potential contamination. Because if you're collecting a sample from a cannula, even though you might be doing those flushes, it doesn't take much of a pure compound that you've infused to contaminate your plasma sample. And then the other point I wanted to make about this study, and one of the advantages I see in bringing our correlation and our understanding of microsampling into PK models is that one of the future steps of PK models, once we've been able to design a good model for our patient group, is to move it into precision dosing. So that would then sit behind dosing software where we use Bayesian forecasting, perhaps with a TDM result, and our patient characteristics to provide a personalised dose of an antimicrobial. So that's our future goal, and we are starting to see that in practice. But what we're seeing here is that the microsampling combined into a pharmacokinetic model can actually give us a really nice result, which we could then move into dosing and TDM using a microsample. So just to give you further into these studies is we looked at the carers and our nurses' perspective on the use of microsampling. There's been about 5 or 6 surveys of home sampling, self-sampling of microsampling. And so I thought I'd just present one from Christoph Stover's lab and in Ghent. And this is where volunteers collected their own sample at home looking for a marker of alcohol intake. 83% of participants were able to generate good quality samples. And then they responded to a survey. 73% of participants responded. 64% rated painfulness of finger prick sampling less than 4, where on a scale of 1 to 10, where 10 was very painful. So they were towards the bottom. Approximately 80% of the volunteers said they'd prefer VAM's finger prick sampling to conventional blood draw if needed on a monthly basis. But that's that's a great result supporting the use of VAMs for self-sampling, but it's a little bit different when we're looking at a pharmacokinetic study in a paediatric intensive care unit. So I thought I'd share also the results of our survey that sat alongside our cefotaxime study. So we have results from 51 carers and 7 bedside nurses that were involved in the study. 96% of the carers and 100% of the nurses would recommend microsampling for collecting blood in paediatric patients. 61% of the carers said that the child indicated no pain, 14% were neutral, with the remainder indicating pain. And 71% of the nurses reported that the children indicated pain. There's a few limitations around this study, though, that I want to make. One is that we didn't survey participants. Sorry, this survey was the participants in the pharmacokinetic study, not the declines. So what it doesn't tell us is the parents that declined to participate, possibly because they didn't want finger prick sampling, possibly because they didn't want their child to be involved in a pharmacokinetic study. So we don't have that data, and I think that's really valuable. It's also worth noting the PICU is a very intense environment, and this is, they're in there with their child. So it is a difficult environment for the parents, but I don't think this study fully describes that perspective. Also, anecdotally, I think it also doesn't tell us about the nurses that decline to recruit patients into the study or decline to offer microsampling as an option. And I think this is more knowledge that we need to understand and to enable microsampling into the future. I also thought I'd share the industry perspective. So this is a report that came out just in 2019. This was a survey that went out to the American Association of Pharmaceutical Scientists and the European Bioanalysis Forum. 39 organisations responded. 46% were large pharma, 18% small pharma, 26% were clinical research organisations, and 5% biotech. 59% of respondents worked in the clinical area. And what you can see from the results is there are far fewer clinical phase studies compared to preclinical studies using microsampling. They found that VAMS was being more frequently used than DBS, and then liquid plasma was being used, liquid plasma as a microsample was being used more frequently than liquid blood. 28 out of 39 participants were using capillary microsampling. And this is something we find in the PICU, where we were with the cefotaxime study, where we were using capillary microsampling. This is commonly used in the PICU anyway, this technology. They're used to collecting a sample into a capillary microsample. The change for them was then to seal the tube and to centrifuge it to harvest the plasma. So that was an additional step of training. But from the industry perspective, the key takeaway is that microsampling is increasingly being integrated into clinical development, with higher adoption in early phase clinical studies and special patient populations. They also found in the clinical studies, 90% of the samples were being collected by healthcare professionals. And so from thinking about the PK studies in paediatric patients that we had seen prior to 2016, I then went and had a look just of the studies that have been occurring since then, so since 2016. And I am quite confident there's probably a few studies I've missed here, but I tried to do a fairly good search. Just based on these results, it suggests there is an increase in the number of PK studies that are being performed in paediatric patients. There's an increased number of patients being enrolled into the studies. You can see there, certainly those top 6 were all quite high into, and there's quite a few studies over the 30s there. There's an increase in the number of samples per patient. You'll notice the 2nd and 3rd studies in Cefazolin, those patients are on cardiopulmonary bypass, and so collecting 10 samples per patient is probably less of an impact on those particular patients. But certainly this increase in number of samples per patient is likely to improve the accuracy of pharmacokinetics. I think, the sample volumes that are being collected, as the study by Professor Manning's group identified, doesn't fully describe the volume that's actually being collected. And then I'd also note that of all of those studies, only 2 of them actually incorporated microsampling. So I think, there's still capacity. Seeing microsampling in use, I think we'll start to see an increase in these studies. But it's interesting that it hasn't really jumped since 2016. And so just to finish up, for me, what I see as the future challenges, microsampling for PK studies does have pros and cons. I'm not sure the current microsampling tools are the best option for a paediatric patient in an ICU, where they do have a cannula available. I have seen studies where they're looking at closed loop sampling, and I think we need to see perhaps a different way where we can still keep a liquid plasma sample, but we're able to harvest it without a big discard. I think that would be of great benefit, because we still want to capture those small volumes. I think, with the future of precision dosing, we can perform bridging studies within PK studies, and these can support future TDM. So I see this as a real opportunity moving forward. If we can perform the studies here, we'll be able to apply them later. And I also think we need to look at adapting our analytical methodology. It's really interesting to see Sophie's talk earlier on the biosensors. I think our analytical and I think, a bedside measurement is going to be our gold standard. But I also think our analytical methodology needs to be adapted perhaps towards ELISA, so we can move microsampling into large-scale pathology laboratories. I'd love to see a better understanding of carer rejection of PK studies and the use of microsampling. I think we need to understand that better. But I'd also really like to get a better understanding of why there has just been that slow uptake of microsampling in PK studies by researchers. I think that's something we could look to do in the future. Okay, thank you.